Good morning, good afternoon, good evening. Thank you everyone for joining us today for this important session on women's health. My name is Mijail Santos and I'm honored to be your moderator today in this live session. Today, we will delve into crucial issues surrounding women's health, including rights, equity, access, and the growing challenge of misinformation. Women's health is a topic that affects every aspect of society. And today is our opportunity to ask questions and hear from our experts how is it that we can tackle these issues head on. We will also highlight stories of success and we will hear examples of how people are advancing women's health in different places. Our distinguished panel members will share their insights, experiences, and challenges, and we will be ready to answer questions posted on the chat. So please do post questions and we will be addressing them during the live. Now allow me to introduce our esteemed panelists. We have Dr. Avni Amin, Unit Head of Rights, Equity and Equity across the Life Course, Department of Sexual and Reproductive Health and Rights at WHO. We have Vivian Ihekasu, Managing Director of Nigeria Health Watch. And we have Alia El-Yassir, Director of Gender, Equity, Diversity and Rights at WHO. So without further ado, let's delve into some questions and a reminder to please send us those in the chat, those that you have in the chat. So Alia, we talk about health for all. Why is it important to focus on women's health in particular and gender equality more broadly?
I could talk for hours, but I will not. I'm here for the first time at the World Health Assembly, but I'm reflecting on when I first came into the UN system, and that was almost 30 years ago, and it was at the time of the Fourth World Conference on Women, which brought us the Beijing Platform for Action. And we actually haven't had a World Conference on Women since that time. But women and health is one of the 12 areas of concerns that were highlighted. And that's because there was a recognition that the women are being underserved. And they're being underserved because there are gender-based discriminations and biases that have permeated systems, including the health system. And it means that women's health needs are not met. So this is not speaking to individual intentions, but it's really talking about systemic issues, structural issues that hold us back as a society. So one example of that, if you look, even, there is a perception that science is objective, impartial, but these biases are embedded. So the health systems also embed those biases. For many years, for decades and decades, the male body has been used as the norm for research and clinical trials. So that means when we're looking for data that is sex disaggregated, so we can look at how there are differentiated experiences, needs, causes, treatments, we don't have it. And that means that we continue to underserve women. So I will use one example so that to give the opportunity for this really great panel to come in on these issues. I know that Dr. Avni is a strong proponent of this. But I think most of us know that cardiovascular disease is like a prominent killer across the world. And I've grown up with an assumption that it affects men predominantly. And yes, there is a higher incidence amongst men, but because that has been the focus, and we have not looked at how it affects women, because actually it is the #1 cause of death amongst women, but that's not what immediately comes to mind to us. And the mortality is higher for women in acute incidence. But this is only available because some of this data has been brought to bear and because there are strong advocates for women's health out there. But there's so many other areas of women's health that we need to unpack and look at these issues.
Absolutely, and I think that's super important to show these examples because systemic bias is really embedded everywhere, as you say, and this is one excellent example, but really every aspect of society has these systemic biases that we inherently understand, and we act on those biases. So at least acknowledging as a first step is something that we really need to work on. So thank you so much for that. I'm going to go to you, Vivian, with the next question. So importantly, a new resolution is being discussed to accelerate progress on maternal mortality. What is the significance of that for women's health?
I think, hearing about the fact that this resolution is in discussion and it was, it was put in place by, countries like Somalia who, have very poor maternal health outcomes is very important. If we look at the SDG targets of having less than 70 deaths per 100,000 live births, it's a very important target. But we, as a global community, are at risk of not meeting that target. And so this resolution, more than anything, is looking to address some of the preventable causes of maternal mortality, because we know that across globally, there are real significant disparities that women face in accessing healthcare. And so what this resolution, we hope, when it's passed, will make sure is we now have focused attention on the urgent need to address some of these disparities that women face when they are giving birth. So we need to ensure that at this political level, that saving a woman's life is a political choice. If we look at countries in sub-Saharan Africa, like Nigeria, where I'm from, that the data tells us that MMR is 576 per 100,000 live births, and that's using the Nigerian Demographic Health Survey. But the WHO figure puts it at over 1,000 deaths per 100,000 live births. And so a resolution like this spotlights the urgent need to make sure that women don't die when they're giving birth, which is supposed to be one of the happiest days of any family's life. And when we look at the impact that has on a family in terms of the children's access to immunization, education, all of those ripple effects on a community and on a family are quite severe. But we know that these deaths are preventable. There's a lot of evidence that has been generated on how we can address it. But up to now, there has not been that urgency that there should be, especially I know in a country like Nigeria, where we have such a high number of maternal deaths, and also other sub-Saharan African countries, to address those issues. And what we hope this resolution will focus are what are the interventions that need to happen to ensure that women don't die giving life. For example, we find that women, when they want to seek health care or when they're in the process of giving birth, there are those financial barriers. You talked about systemic barriers. Some of them are financial. A woman has no access to her own source of income. There are cultural issues that can impact it. Looking at the financial aspect, the high cost of healthcare often means that a woman, rather than going to a health facility to give birth, will give birth in her community. For example, in Nigeria, you'd be shocked to hear that only two-thirds of women actually give birth in a health facility with a skilled birth attendant. And many of them give birth in communities. How do we ensure that a lot of the discussions around why women are dying is not addressed? We need to ensure that with this kind of resolution, it's addressed. So financial barriers is one. And then the health system that can support safer childbirth, that needs to be strengthened, starting with what we always talk about, primary healthcare. So primary healthcare means having the adequate skilled workforce, and when that woman is in need, or when she's giving birth, or when she's seeking healthcare, or going for immunization for her children or otherwise, she has skilled support, skilled birth attendant addressing, meeting her, and also the skilled workforce that when she's about to give birth or when she's seeking healthcare, it's also respectful care. So this resolution, when passed, I hope, will ensure that progress that has stalled so far, we hope will be accelerated at the higher level, at the political level. And as I said, it has to be a political choice to save women's lives more than anything.
Absolutely. Thank you so much. I think I picked up everything you said, but two especially special things you said. One is that maternal mortality is preventable. And that's something that we continuously need to remember, not only because it affects all parts of society, as you say, the family, health workers. It's really something that is interconnected with everything that we have as a society. And the second one is the numbers that you gave. It's often so impactful to talk about the stories, but also the numbers are absolutely critical to address, and it's an urgent issue that we need to continue to address. And with this type of resolution that's being currently discussed, we hope that we continue to improve and that we continue to accelerate that progress that has been achieved. It's also good to recognize that there's been so progress. But there's still so much to be done, and I'm so glad that all of us are here, because this topic is something that, of course, we all feel very passionate about, but also something that we're working towards. And I really think with our audience taking their part in these issues, it will be easier for us to continue advocating and to continue to work for women's and maternal health. So thank you for that. I'm going to pass over to you, Avni. Sexual and reproductive health and rights underpin progress in maternal health. What progress has been made in this area, and are you worried about setbacks?
Thank you, and it's a pleasure to be here. I just wanted to pick up on something Vivian said, and Dr. Mahmoud Fatala, who's a very famous OBGYN, who set up who was one of the first directors of the Department of Sexual and Reproductive Health and Rights, who said, women are not dying because of childbirth. Women are dying because societies have yet to decide that their lives are worth saving. And that's a very powerful statement. We are, as you said, maternal health, maternal mortality is entirely preventable. But why it's not being done is because women face discrimination and inequalities from a very young age. When women are forced to marry early, when they're having children early, when they're having pregnancies very frequently, poorly spaced, when they don't have access to contraception to space the childbirth, when they actually don't have information and control over their bodies, when they suffer violence, when they cannot access healthcare because they're restricted at homes. These are all conditions that contribute to not only adverse maternal health outcomes, but health outcomes throughout their life course. And I'll tell you a story, a very personal story. I was raised by my aunt, whose stories I grew up listening to. She was forced to marry at the age of 14. She had her first child at age 16. She had to drop out of school. By the time she was 26, she had 5 children. She was widowed by the time before the age of 30. At age 40, she was diagnosed with diabetes. Age 45, menopause. Cardiovascular disease followed soon after. And at age 75, she died of kidney failure. And what that made me think and reflect, and I just wanted to leave everybody with this message, is that the conditions that influence women's reproductive health, maternal health, and their health throughout the life course are often not just related to biology, but they're related to the discrimination they face. And right now, when you think about the setbacks that we're experiencing, of course, progress has been made. We've been very successful in making progress and making sure that women are having antenatal care, women are having services in many areas. But the setbacks are because there's this tremendous pushback against women's rights. There's a pushback against the notion that women have bodily autonomy and the right to control their bodies. And there is a pushback in many countries where at the national level, laws, for example, are being reversed that protect and promote women's rights, as we've seen in the case of female genital mutilation. So what we have to maybe think about is that these setbacks are man-made. These setbacks are because governments decide and societies decide that women's lives are not worth saving. We saw this during COVID. Of course, everybody talked about higher incidence of COVID and mortality among men. But what we did see is that because of COVID, women who were not protected by social protection, women who were tremendously burdened by caregiving roles, women who were stuck at home with abusive partners. Those were the women who suffered the most. And what that tells you is that any gains that we make in women's health are very precarious and very fragile. And all it takes is pushback or crises like COVID or any other type of crisis that really pushes us back in reversing the progress we made.
Absolutely. And I think COVID taught us how at risk women's health is overall. But also, thank you so much for sharing that story, that personal story, because it really shows how, again, these aspects of women's health are present in all of our lives. And actually, I want to, for the benefit also of our audience, I wanted to ask if you can maybe explain what we mean by health throughout the life course, right? Because we often say this is something that's, well, women's health is there throughout the life course, but what does it really mean?
What it means is that we have to start valuing women's lives and health from childhood. In the country I come from, in India, the birth of a female child is not celebrated. Women, and particularly girls, often face discrimination. They are the least likely to be taken to a health facility if they are sick. They are undernourished. Many times, by the time these girls hit puberty, they have anemia. They then become pregnant at a very young age because they are married by the time they're 15 and 16. So they're already carrying that cumulative, what you call adversity in their bodies because they've been malnourished from childhood. They're getting married early. They have anemia. They become pregnant early. They have multiple births. And all of this then carries throughout in terms of what people call, in the mental health field, the body keeps score. We know that the body, as it ages, is not just about what you experience in that moment, but it's also your life experiences that you've carried from a very young age. And that's what ends up happening is that you age, and in many cases people now are talking about something called epigenetics, which is that discrimination embeds in your physiology. And what that does is that it actually shortens your lifespan. It actually adversely affects your health trajectory as you age. There is a very interesting study from Democratic Republic of Congo, which, as you know, has suffered many years of war. And what it showed is pregnant women who were raped had so much accumulated trauma that they had lower birth weight babies because of the embedded trauma because of the embedded trauma that they experienced, and that carried through to the next generation. And that's what we mean by life course.
Thank you so much for explaining that, and I think that's a key message as well, because the whole conversation also is around how women's health affects every aspect of society. And I think by understanding this women's health throughout the life course, it's very easy also to understand why everyone has a role to play. This is not something that certain parts of society have to be fighting for. It's something that affects every single one of us, because it includes maternal health, it includes newborn health, it includes child health, adolescent health. As I think you just mentioned, there are young people having kids. This is women's health. All of these aspects continue to affect or to influence how people are growing up and are developing health-wise and society-wise, really. So thank you so much for that. I'm going to come back to you, Alia. But really, we can start a little bit more of a conversation, and please jump in if you have something to say. So, women's health issues often get reduced to reproductive health, but it's a lot broader than that. Why have other issues received less attention, and what needs to change for this to stop happening?
I think all the panelists have spoken to why it happens. I would just like to underscore that reproductive health is an essential part of women's health, as has been highlighted already. And I think when we talk about life course, we would apply that to anybody. Nobody's health should be constrained to their reproductive function alone. So I think that's what we're looking at. I see WHO really making strides in this area. WHO is now leading some of the conversations around dementia, menopause, suicide, looking at mental health issues, because there are gendered differences. And we need to unpack. These are complex issues. We will make a mistake if we oversimplify. So if you look at, the women are disproportionately affected or exhibit dementia. Is this because they're living longer? Well, now the evidence is being accumulated because people are actually looking into it, saying that actually menopause may be affecting. But when we look at menopause, WHO also is looking into this very carefully. There's very little known amongst women about what to expect during menopause. There's social stigma that is playing a role, really speaking to what Avni is talking about. Health professionals don't have the information. There is underinvestment in this area of work. You look at some mental health, suicide. Yes, there's higher rates of young men losing their life due to suicide. But sometimes you lose between the lines the fact that actually the attempts at suicide are higher for women. So they're just less successful in their suicide attempt. So that really speaks to it. So then as a mental health professional, you need to know that, and so from a prevention angle, have that approach. What I would say we would really need to do is question assumptions, question systems, inquire further, unpack, deconstruct these really complex issues, invite others into the conversations. And I would say we really do need data, evidence, and knowledge. It's missing. And that means we need to have it disaggregated, sex and age at minimum, but there's many different ways in which we can look at data. When I talk about data, I always say we treasure what we measure. So if we're not measuring it, we don't really value it. So we really need to invest in this area. And I'm really coming into this role, I really commend WHO for signing up to the sex and gender equity in research guidelines. So really walking the talk as WHO on this. I think this will go a long way to supporting at least WHO's efforts in this area. I would also say watch out for pitfalls, because I see in the global discourse, for example, the digital transformation era. We look at digital as resolving solutions, artificial intelligence, machine learning. But it's only as good as the data that is fed into it. So if the data is biased, then it is going to make it, further entrench and permeate all the digital systems, including data systems and health systems that are based on this. So I think there was a couple of years ago, there was a study that looked at over a period of 30 years, 133 systems, not specific to health, but across industries. And they showed a 44% gender bias and a 26%, I believe, or thereabouts, of racial bias. So we have to be really careful about these solutions, that we make sure that we tackle them early on. And finally, I would say what would be really important is also to focus on women in health. I think you talked about COVID. Well, I think if COVID showed us anything, we have to recognize 67% of the paid health and care workforce are actually women. So how are we better enabling them? So not only looking at women as passive, sort of recipients of health that is done by others, but really recognizing the women that are embedded in the health system, health and care, because we are talking about health and well-being. So I really want to drive that home, and really to say that we want to address inequalities to have better health outcomes, but better health outcomes will also address those inequalities that exist. So I really think that this is something that we have to do together.
Thank you so much. It's indeed a cycle of inequality. And then I love that you talk about biases in data, how it is important to put that information out. And you talked also about health workers getting the right information, understanding what is it that it's being studied. And I'm gonna jump a little bit to you, Vivian, because we met a couple of days ago in another session, and we were talking about misinformation. So there's lack of information getting to health workers and really to society, but also there is misinformation. And that misinformation is continuously growing. I think I started the session also in the introduction. I mentioned misinformation because we see more and more cases where women's health is being targeted by this, or is being affected by this misinformation, which is, in my view, one of the biggest risks. Because if the information, not only there's not information getting to the right people, but when it does, it's not the correct information. So, what do you think about that, Vivian? Also, before you respond, that I would like to invite all our audience to also ask questions, because in this topic of information and accessing information, this is our opportunity again to ask experts and to get some of the information that we can use in our work around women's health. So, Vivian, I hope.
Interesting angle to look at when you look specifically at women's health. I know when we look at misinformation around things like vaccine hesitancy, there are other forces that are in place there. What we found, and what I've often found when it comes to misinformation around women's health, a lot of it often is linked to health literacy. So when a woman is not informed about, for instance, a simple thing, family planning, there are a lot of misconceptions, and some of them is cultural, religious, but some of them is just cultural perceptions around family planning. Something as basic as, in a country like Nigeria and many sub-Saharan African countries, that some family planning commodities can lead to infertility. And the minute you kind of put that out, you've completely shut down any discussion about family planning services or commodities. And also, there are often people who are very, very powerful in the communities. So religious leaders are often sometimes advocates against, ironically, access to family planning, commodities and services. So, we found in a place somewhere like Nigeria, whenever you're doing any advocacy around using access to family planning or otherwise, these are often important stakeholders that you want to engage to dispel any misconception about misinformation. Why I said, health literacy is also one of the barriers, and why we need to keep our girls in school for very, very obvious reasons, is even something like breastfeeding. In certain communities in the north of Nigeria, the first milk is seen as unclean. We all know the nutritional value of something like that. And so a lot of it sometimes is misinformation, but some of it is also just comes down to poor health literacy. And if that's strengthened and ensuring that the correct information is passed to women and girls at the time they need it, thinking about things around stigma, that's also down to sometimes poor education. It's ironic that often things around women's health are stigmatized. You talked about the life course. Menstruation is stigmatized. Go across when a woman is over the age of 50, whatever, and she's going through menopause, that's so stigmatized. So how do we use education, if that's the right word, and changing some of these social and cultural norms to take away that chance of misinformation, now reducing women's access to healthcare or even the way they perceive their own health. And so we know you have to be, as a young girl, proud and not feel embarrassed because you have your period, and a woman not scared to say menstruation. That word is often, menopause, because that word is often, even for healthcare workers, you don't want to ask a woman, are you going through menopause? As if it's a word you don't speak about. And just to add one more thing, you talked about evidence, data, and research. We don't have enough innovation around women's health issues. So we are still using the same products that women have used for many generations. And that is down to not investing enough in research around women's health. And that needs to be amplified and increased more than anything. Yeah.
I wanted to pick up on a couple of things that Alia and Vivian said, and maybe just add to it. I think one of the things, and I'm glad you said that reproductive health is central to women's health throughout the life course. We know now, and there is increasing data, for example, that estrogen fluctuations during menopause are linked to mood disorders and depression. and we don't make the link between women's sexual and reproductive health and mental health. We've had for a long time data in WHO that my department produced that shows very clearly that exposure to sexual violence and exposure to domestic violence increases the risk for women to attempt suicide by 4.5 odds risk factors, twofold increased risk in depression, and twofold increased risk in in substance use disorders. And we don't make the link between women's sexual and bodily autonomy and their mental health. We know, for example, that there is almost a generational change in women reaching menopause earlier, and we know that early menopause is now linked to a higher risk of cardiovascular diseases. So we really need to think about how sexual and reproductive health is central and critical to women's mental health, women's non-communicable diseases like cardiovascular diseases, hypertensive risk, etc. And the second thing I wanted to pick up was on the misinformation and disinformation. And I agree, I think health literacy is absolutely critical, and that is what we need to focus on with women. I will, though, say that I think there is a concerted effort to spread misinformation and disinformation that is particularly targeted at women's bodily autonomy. So the two areas where we have always faced misinformation and disinformation in the work that my department does is on abortion and on comprehensive sexuality education. And the way to counter this misinformation and disinformation around these two topics, because they are very contentious, is to provide the data and the science and the evidence. We know that comprehensive sexuality education does not increase risky sexual behavior among adolescents. We know that it's protective. We know that it reduces rates of STIs. It protects against HIV risk behaviors. And we have to constantly remind people that the science says otherwise. And I would say the same thing for access to safe abortion. There is so much deliberate misinformation spread in social media and elsewhere that the evidence that we have shows very clearly that this is not the case. And we have to constantly, as WHO, talk about the science and the evidence to counter this kind of misinformation.
Thank you so much. I think this has been a really, really great conversation. And I just want to acknowledge my colleagues here at WHO are sending me all the questions and comments. And thank you to countries from that have joined this live. We have people from Guyana, India, Nigeria, Brazil, Indonesia. Thank you so much for those comments. Romoke Ayoyemi is saying, "You're right, Ma. Lots of Nigerian mothers give birth at home due to the assumed cost of hospital bills." Veronica Douglas says, "Thanks for this informative and serious discussion on women's health." And I think we're here seriously talking about this because it's, as we said, an urgent issue, an issue that needs to be a priority and needs to continue to be a priority. So yeah, thanks for bringing women's health to center stage. Also, women's health is more than getting pregnant. We work in midlife health and menopause space. Thank you, Miara, for that. So I think if we can wrap up with one last thing. What is the key demand? I mean, and maybe if we can say in one sentence, what is the key demand that you think women should be making for their health right now? So let's start from that side. And Vivian.
What I think we have to understand that focusing and accelerating progress on women's health is not a nice to have, it's a must have. Because there's a strong economic argument, as we saw with the World Economic Forum discussions, which saw the impact of investing in women's health. What that would mean is the global economy will be boosted by $1 trillion annually by 2040 if we invest in women's health. So it's an economic argument, not just a nice to have.
Thank you so much. That was
More than one
great
sentence.
with many commas. But no, it's true. It's true. I mean, I think it's so key, everything you said. So, Avni?
Focus on the life course approach. Listen to women tell you about their health from their perspective. Invest in women's health research. address both the biology but also the gender and the other social inequalities, because those are two things that are interconnected.
Thank you so much. And Alia?
So I think we're directing our messages to the policymakers and the decision makers, and that is really important because that's the system that can make the change. I think it's really important not to put this burden on the women themselves to demand their rights. And women do have agency, but if the systems are against them, that will only go so far. So we really need system change. I think would be the big message, and that there is something that every single decision maker and policy maker can do. Look at who is invisible in the conversation and make sure that they are part. Those who are affected by the issue, don't make assumptions about who that is.
Thank you so much. And if I may, I will end with 3 takeaways that I had. One is engage. Engage. Everyone needs to engage, right? It's not women that have to engage in women's health. It's every part of society that needs to engage. Second, question. If there is information that you get, have the critical mind to say, is this the right information? Is this correct information? Is this based on data, science? How can I back the information that I'm getting? And third is talk about women's health, because only with this we're going to end stigma. Only by talking about women's health, we're going to empower people to also talk about women's health, and again, to prioritize this key issue that affects us all. Thank you so much, everyone, for joining, and please do post more questions. We'll try to see. Thank you so much.
Thank you.
It's completely unacceptable for patients and hospital staff to be unsafe.
This is the worst situation I have seen in my life.